ulcer disease results from the imbalances between mucosal defense mechanism and the damaging factor that causes chronic gastritis. So damaging factors are gastric acidity and peptic enzyme. The protective factors are surface mucus secretion, bicarbonate secretion into the mucus, mucosal blood flow, epithelial barrier function, and epithelial regenerative capacity, and elaboration of prostaglandins. The injurious agent usually cause H. pylori infection, non-steroidal anti-inflammatory drugs, tobacco chewing, alcohol, gastric hyperacidity. So it results in ulcer. The peptic ulcer, the gross sites are usually proximal duodenum. That too, the anterior duodenal wall is most common. In stomach, lesser curvature of stomach at the junction of antrum and body is the most common site. Grossly, usually peptic ulcer is less than 3 millimeter in diameter, usually single, solitary, oval, punch-out lesion with a clean base, and there may be hanging mucosal fold. The picture shows the peptic ulcer in the stomach with a hanging mucosal fold, and lower picture shows the microscopy of the peptic ulcer. The peptic ulcer, which is an active ulcer, shows thin fibrinoid debris on the floor because these debris are less because of acid and pepsin secretion. Underlying, there is a predominantly neutrophilic infiltration into lamina propria, and there is a granulation tissue infiltrated by mononuclear leukocytes, that is monocytes and lymphocytes. At the base, there is a fibrous and collagenous form. Next is the tumors of stomach. There are two gross types, the ulcerative and diffusely infiltrative, that is also called as Linitis plastica. The picture, the difference between peptic ulcer and malignant ulcer is usually larger than 3 millimeter in size. Again, it may be solitary, but it has everted edges. Right? But in a Linitis plastica, there is a diffuse infiltration of the wall of the stomach, converting stomach like a leather bottle. So it is called as a Linitis plastica. This is the microscopy of adenocarcinoma of stomach. The most common tumor of the stomach is adenocarcinoma. As you know, adenocarcinoma is a tumor arising from the glandular epithelium, which forms the gland-like structure, may not be functional. So this is the microscopy of adenocarcinoma of stomach. Next, coming to the intestine, there are some causes of intestinal obstruction. One is the herniation. When the hernia is non-reducible, it may cause obstruction. The adhesion between the loops of the intestine. Then there is a volvulus, there is a twisting of the loop of the intestine and intersusception. Next, the infectious lesions in the intestine. The first is a typhoid infection, that is the enteric fever, that is caused by Salmonella typhi and paratyphi. The Salmonella infection usually affects the Peyer's patches in the terminal ileum with the draining lymph nodes are involved. The Peyer's patches, the alienation of the Peyer's patches is a parallel to the long axis of the intestine. So when there is a hyperplasia of Peyer's patches, which is actually a lymphoid tissue in the intestine, there is a sloughing of or a necrosis of a superficial mucosal layer. So the oval ulcers, which are usually multiple, are produced in the terminal ileum with a long axis parallel to the long axis of the ileum. Microscopically, it shows the accumulation of neutrophils in a superficial lamina propria and the macrophages containing bacteria, RBCs, and the nuclear debris are mixed with the lymphocytes and plasma cells. So that is called the lymphocytosis and erythrophagocytosis is usually seen in the microscopic picture of a typhoid intestine. Next, infectious lesion in the intestine is the tuberculosis. These tuberculous ulcers are usually oval ulcers, but they are long axis as perpendicular to the long axis of the intestine with a fibrosis and scarring, usually in the distal ileum and cecum. The fibrosis and scarring is because this is a chronic infection and it results in a chronic inflammation of the intestine which may result in the intestinal obstruction due to the excessive fibrosis. The microscopy of tuberculous intestine is typical of any other tuberculous infection. So it shows the typical tuberculous granulomas in the submucosa and in lamina propria with a submucosal ulceration. Right? So what is granuloma? So granuloma is a localized collection. There is a centralized caseous necrosis surrounded by the lymphocyte epithelial cells and the giant cells which are Langan type. What are Langan type giant cells? With the nucleus is arranged at the periphery in a horseshoe manner. So the typical granulomas are seen in the microscopic picture with a central caseous necrosis, epithelial cells which are the modified macrophages surrounded by the lymphocytes and Langan type of a giant cell. Next lesion in an intestine is Armatic Colitis, usually affects large intestine. The cecum and ascending colon is commonly involved. Sigmoid, rectum, appendix may be involved. So in amoebic colitis results from the infestation by the parasite that Entamoeba histolytica. Right, Entamoeba histolytica, the cysts are ingested which resist the acid digestion in the stomach, reaches the intestine, develop into the trophozoites and they bury into the mucosa and form the flask-shaped ulcer. Right. So this is a picture of the microscopy of amoebic colitis. Upper picture shows the flask-shaped ulcer. So there's a narrow neck and the broad base. So the trophozoite enters the mucosa, goes into the submucosa and start digesting the mucosal area, which produces the ulcers, which is a flask shape. Lower picture shows the trophozoite, which is a quadrinucleate. Next is the tumors of a colon. So the first is a benign tumor, which is the adenomatous polyp. Adenomatous polyp is, as you know, the adenoma is a benign tumor arising from glandular epithelium. So this is a picture of adenoma, which may be pedunculated. That means it has a stalk, or it may be sessile. In the picture, it shows the sessile growth. So it is classified as a tubulous adenoma, tubulovillus adenoma, or a villus adenoma. So villus adenoma has the prawn-like processes with a central fibrovascular core. If this picture predominates in a 75% of the adenoma, then it is called as a villus adenoma. If the fibrovascular core and finger-like projections are absent and you see only the normal-looking glands of gland, then it is called as a tubulus. In between, it is a mix. Then it is called as a tubulovillus adenoma. This is a benign condition, but the villus adenoma may give rise to adenocarcinoma because of a rapid growth of the cells, which may be benign, but they may get transformed into the anaplastic or carcinomatous cells. Next is the adenocarcinoma of colon. So this is a malignant tumor of the colon or intestine. It is distributed at entire length of a colon. But the tumors of proximal colon usually grow at polypoid or exophytic mass, so they do not obstruct the lumen of the colon. While the tumors of the distal colon tends to be annular, producing napkin ring-like constriction. So usually the tumors of the colon are grossly classified as the polypoid exophytic mass, which is coliform-like, or the annular infiltrating mass into the wall, causing the constrictions like a napkin ring. And the third type is of ulcerative type. As you know, the malignant ulcers have everted edges. It grows above the surface of the ulcer. So this is the gross specimen of an encircling adenocarcinoma of a rectosigmoid region with a normal appearance at the right of the tumor, and the tumor encircles the colon and infiltrated in the wall. So it is an infiltrating type of adenocarcinoma. So this is the exophytic polypoid cauliflower-like mass of the adenocarcinoma. Is a microscopy of adenocarcinoma. So that when you see any adenocarcinoma, it is a tumor arising from the glandular epithelium. It forms the gland-like structure. There may not be lumen, or then now be functional gland, but the glandular-like structures of the epithelial cells. Usually, there is a features of a malignancy like the invasiveness. So in the slide, you can see the malignant glands invading into the deeper submucous tissue. So it may go up to the serosa. So this is a high power picture of the same adenocarcinoma of the colon. Again, here is the adenocarcinoma, which the glands are much larger and filled with necrotic debris. So as there is a rapid growth, the central cells are devoid of blood supply and may suffer from the necrosis. So this is the rapidly growing adenocarcinoma of colon. Thank you.